This is now the conference's second year of running a research competition, and we have received lots of amazing entries from various different dental schools. So thank you to everyone who took part by submitting an abstract. I now have the pleasure of introducing our 3 finalists for the research competition, who are all in their 5th and final year of dental school. So in no particular order, our finalists are Sathyam Sharma, Nasir Zishan Bashir, and William Timmis. Our 3 finalists have all submitted 5-minute pre-recorded videos, which will be played, followed by a live 2 minutes of Q&As by our judges, Prof Glennie and Prof Walsh, and the winner will receive a £50 prize. I will now start by playing Sathyam Sharma's submission from Queen Mary, University of London.
Good afternoon, everyone. I hope you've enjoyed the research summit so far. On behalf of the Open Up research team, working collaboratively across 5 different dental schools, my name is Sathyam Sharma, and I'll be presenting the research poster titled, How Effective is Workshop Teaching and Improving Dental Students' Confidence with Patient Mental Health? So let's start at the beginning. Why did we think that the confidence of dental students when talking to these patients was an issue? Well, we looked into the existing research and saw 3 main things. Number 1, psychiatric disorders are becoming more common in the UK, with 1 in 4 people experiencing a mental health problem in any given year, and this number only set to rise given the current situation. Number 2, there is a link between mental and dental health, with psychiatric conditions being linked to self-neglect and unhealthy coping mechanisms that can result in dental decay and disease. And number 3, practitioners are not confident in their manner and knowledge of these conditions. This is therefore an issue of education, which is where we thought we can make a difference. Our aims and objectives were therefore, firstly, to explore UK and Irish dental students' confidence to see where issues in education might exist, and secondly, informed by previous research conducted within another UK dental school, as well as the Cochrane review on successful educational interventions, to develop and assess the effectiveness of the interactive workshop we subsequently created to address the found issues. Moving on to methodology, our first method to explore students' confidence was creating and distributing a survey that presented clinically as students with different patient scenarios and sought to assess their baseline confidence in response to these. The scenarios topics included depression, anxiety, and eating disorder, and a patient on antipsychotics. From this, we wanted to deliver our interventional workshop. These workshops explored dental manifestations of psychological disorders, mental health awareness, and include fictional case discussions of patients with mental health conditions. Importantly, pre- and post-workshop surveys were also implemented to allow us to assess changes in confidence. So, what did the results show? Well, the scenario-based confidence survey showed that out of 225 respondents, the overall self-reported student confidence was low, with an average score of 4.86 out of 10 across all 4 questions. Looking at figure 1, we can also see that confidence was lowest in scenario 2, where an undiagnosed eating disorder was directly impacting treatment. In terms of the workshop, 63 students in total participated across the 5 different dental schools, with an average of 12.6 participants per workshop. It should also be noted that whilst Barts and Dublin were able to deliver their workshop in person, Newcastle, King's and Dundee Dental School were, much like this research summit, forced to adapt and deliver their workshops virtually due to the pandemic. Regardless of this, in terms of the pre- and post-workshop surveys, the same 4 questions were given to all participants before and after each workshop to quantitatively assess how effective the intervention was. Questions 1 to 3, present in the following table, ask participants to rate different aspects of their confidence on a 5-point scale, from 1, not confident, to 5, very confident. And the 4th question simply asked participants if they could describe the available referral pathways for patients who may need additional support from other mental health services. Looking at the results, there was statistically significant improvement in the self-rated confidence of participants after every single workshop, with figure 2's descriptive plots of questions 1 to 3 depicting no overlap of the pre versus post-workshop error bars. Additionally, there was an overall 79% increase in the number of participants who can now describe available referral pathways. Looking at figure 3, we can also see some of the positive comments made by participants praising the workshop. Whilst gratifying to hear, these comments also act as qualitative evidence of the workshop's benefits. Putting all this research together, we can therefore confidently come to the conclusion that interactive workshop teaching is an effective method to significantly improve the low self-reported confidence of UK and Irish dental students when addressing patient mental health. From our research, we can also make the following recommendations. 1, the implementation of interactive workshop teaching within the BDS curricula to ensure graduates can properly meet GTC learning outcomes. And 2, support for the development of guidelines that aid dental teams in liaising externally with appropriate psychiatric services when necessary for their patients. So thank you for your time. I hope I was able to succinctly guide you through our research poster. I would like to say, if you're interested in learning more about this important topic, scan the QR code on your screen now to read one of our previously published papers. Thank you and enjoy the rest of the conference.
Thank you for your submission, Sathiam. I would now like to invite Prof.
Authors of this research were Emma Elliott, myself, Satham Sharma, Dr. Alia Omar, Dr. Dominic Hurst, and Dr. Catherine Marshall from BUDRC, with contributions from Alex Blair of Dundee Dental School, Harriet Beatty and Aurelia Claudia of Newcastle Dental School, Anusha Chopra and Gopi Patel of King's, and Alison McCullough, Shahad Busnena, and Barsha Lal of Trinity College Dublin Dental School.
Thank you for your submission, Sathiam. I would now like to invite Prof. Glennie and Prof. Walsh to ask a few questions.
Hi, Tanya, do you want to go first or should I chip in?
Yeah, you've started, so yeah, carry on.
Okay, thank you for the presentation. That was great. I'm just interested to know about the content of the workshop, how that was developed and whether it was standardized across all participating dental schools. And also, you talk about it being part of the undergraduate curriculum. I just wondered whether you felt there was a certain time that it should be embedded within the curriculum. Do you know, should it start in BDS year 1 or should it actually be sort of drip fed throughout the whole 5-year programme?
Hi, can you hear me?
Yes, can. Yeah, thank you.
Yes, okay. Thank you for your questions. To answer the first question, the workshop was created alongside the help of Dr. Catherine Marshall, who was a psychiatrist, and then also her supervisor, who was a dentist and psychiatrist, sort of dual. So between the two of them, we worked together to create the workshop. The content mainly structured around, firstly explain why we thought it's important, dental students and dentists know how to treat these conditions. Some of the specific dental presentations, so that if a dentist has this patient come into the clinic, they can maybe start to suspect and get an idea. And then also tips on just how to have these discussions, because there's still a bit of stigma. People can still be a little bit nervous. And then lastly, finishing up with the available referral pathways. And then finally, the actual really big meat of the workshops was sort of these scenarios, which then invited sort of open discussion, and people would ask a psychiatrist sort of any and all questions, no stupid question. And I think that was one of the parts the participants really enjoyed, because it let them really sort of get to grips with how to have these somewhat difficult conversations. To answer your second question, we're actually currently in the process of converting this to an e-learning resource here at BUDRC. And the current plan right now is to introduce it at the end of 2nd year, beginning of 3rd year, so just before students go into clinic. So they haven't had any clinical experience yet, but it's sort of giving them the foundation, the foundational communication skills, just to sort of have these conversations, much like any other sort of communication skill workshops they may have before they actually go into clinic.
Thank you. Thanks so much.
Hi, I thought that was a really interesting presentation and a really kind of like timely and relevant topic, as you said in your presentation. I'm just kind of, I mean, you seem to get really good results from the workshop. I'm just kind of interested in the people that didn't participate. So this was a self-selecting sample, so people volunteered to go to this workshop. Were you able to collect any information on those people who declined to participate? Any reasons why they may not have wanted to take up this workshop invitation? And how do you think that would kind of like impact on implementing this kind of in practice?
Okay, again, thank you for your question as well. Unfortunately, I don't think we got any specific feedback regarding that. However, I can say when we initially ran our workshops here at BUDRC, one of the big issues actually was just came out of timetabling. We sort of were running this sort of around exam season. It was a little bit difficult, especially also organizing alongside a psychiatrist. So we ended up having to go, I think, sort of after a whole block of morning lectures. It was lunchtime. Some people weren't that keen on staying behind. In terms of other universities, because they were done remotely, as in we had our delegates run them. I'm not entirely sure. In terms of future implementation and such, obviously, I think, you know, speaking quite frankly, there are some students who don't always engage, particularly if it is e-learning. However, I did speak to a couple students at the BARTs who did attend, who I personally know to be a little bit more relaxed when it comes to sort of engagement, and they afterwards told me that themselves that, you know, actually this was quite an important topic and quite an important lecture, and they were glad they attended. So that's a bit anecdotal, but I think, like you said, the importance of the topic is sort of, I think, so significant that hopefully it should perhaps overcome any sort of engagement issues, I hope at least.
Okay, thank you.
Yeah, thank you.
Thank you for answering those questions, Sathiam. I will now play Nasir's submission from the University of Birmingham.
Good afternoon, my name is Nasir Bashir and I'm a final year dental student at the University of Birmingham. I'll be presenting today some research I've done that centres around the use of artificial intelligence to develop and validate predictive models for periodontitis. So to give some background, periodontitis is an inflammatory disease process, and contemporary research has highlighted that it has bidirectional interactions with numerous other conditions, which include diabetes, cardiovascular disease, rheumatoid arthritis, and chronic kidney disease. Given this, it would be useful for both medical and dental professionals to be able to accurately identify patients at high risk in order to help preserve their systemic and oral health. This is especially true if we can develop ways of predicting periodontitis in a non-clinical environment. The problem we face is that there are numerous risk factors which interact in a complex manner to bring about disease occurrence. One way to try and tackle this challenge that has not been previously attempted is the implementation of artificial neural networks. Artificial neural networks are a machine learning protocol which aim to mimic the neural networks observed in the brain in order to facilitate complex nonlinear analysis. The aim of this study was to train artificial neural networks on large-scale population-based data in order to develop and validate predictive models for periodontitis. This study was designed and reported according to the TRIPOD guidelines. The data used were taken from the National Health and Nutritional Examination Surveys, or NHANES for short. The NHANES studies were conducted from 2009 to 2014, and they are multi-stage, weighted, stratified, cross-sectional studies, which aim to take a representative sample of the US population. All participants are interviewed, followed by invitation to a mobile examination center for further medical and dental examinations, measurements, and tests. In this study, two case definitions were used for periodontitis: the 2012 CDC AAP case definitions for population-based studies, and the 2017 EFP AAP World Workshop case definitions. The CDC definitions classify patients as having either no disease, mild disease, moderate disease, or severe disease. In this study, patients with moderate or severe disease were classed as periodontitis cases. The 2017 EFP definitions classify patients as having either stage 1, 2, 3, or 4 disease. For this study, patients with stage 2, 3, or 4 disease were classed as periodontitis cases. Covariates in the predictive models included age, gender, ethnicity, household income, educational attainment, smoking status, and diabetes status. Diabetes status was assessed in two separate manners. Firstly, according to the patient-reported medical history, and then secondly, the laboratory data for each patient was analysed to see if their glycated hemoglobin levels and fasting plasma glucose levels would classify them as having diabetes. Finally, patients were asked to give a self-assessment of their oral health on a 5-point scale, and this was incorporated into the predictive models. Overall, 4 predictive models were developed, one for the CDC case definition without the lab data, and one for the CDC case definition with incorporation of the lab data. This was then repeated for the EFP case definitions. The full process for training the artificial neural networks is presented on screen. To assess predictive validity of the final models, 6 outcome measures were assessed. These were area under the curve for the receiver operating characteristic, accuracy, sensitivity, specificity, positive predictive value, and negative predictive value. I programmed all preliminary analyses in Stata and then exported the data into the purpose-built software Neural Designer, where I designed, modeled, and trained the artificial neural networks. Moving on to the results, the included cohort was composed of 9,631 participants, and these were allocated in a 60-20-20 split for training, selection, and validation of the neural networks, respectively. The characteristics of the cohort are presented on screen, and I've divided the cohort into those with and without periodontitis according to the CDC case definitions. Mean age is presented in years with standard error in brackets, and all other variables are presented as number of participants with the corresponding percentage in brackets. Patients with periodontitis were, on average, around 8.5 years older than those without. They were more likely to be male, more likely to be of non-Hispanic, Black, or Mexican American ethnicity. They were more likely to have an educational attainment below university level, and more likely to have an annual household income below $20,000. Also, they were more likely to be a current or ex-smoker, more likely to have diabetes, and more likely to self-report their oral health as being fair or poor, rather than excellent, very good, or good. Following characterization of the cohort, the neural networks were trained and validated as previously outlined. The predictive validity for all 4 models is presented on screen, and in brackets are the 95% confidence intervals. Essentially, all models had an accuracy, sensitivity, and specificity above 70%, as well as an area under the curve for the receiver operating characteristic of above 0.8, which indicates excellent predictive validity. Also, the models which incorporated laboratory data were not superior in any of the domains of outcome assessment compared to the models which only used non-clinical patient-reported data. To conclude, artificial neural networks can reliably predict the presence of periodontitis using only data which can be obtained in a non-clinical setting, meaning they may facilitate high accuracy screening of patients for effective allocation of resources. Thank you for listening, and feel free to ask any questions.
Thank you for your submission, Nasir. I would now like to invite Prof. Lenny and Prof. Walsh to ask a few questions.
Tanya, I'll let you start on this one.
Okie doke. So again, yeah, another really interesting presentation. There's masses going on in that research project, isn't there? Lots to talk about and lots of results reporting. And actually, I'd like to commend you on the way that your results were reported as well, because you provided everything that we'd actually want to see on there. Mine's kind of like, my question is more kind of conceptual, if you like, really, in that NHANES is based in the US and a standard set of information that's collected through their surveys. I just wondered whether you felt that the variables that were collected were sufficient for the predictive model. So is there any other information that you believe may have had an impact or could be incorporated into a predictive model that wasn't collected in NHANES? And the second question is that whilst it's great that you have statistical software that can build these complicated networks, sometimes if you're kind of reliant solely on the numerical values, you can get some quite unlikely associations coming out purely as an artifact of statistics rather than clinical plausibility. So I just wondered whether there was any opportunity for clinical input in the building of these models.
Yeah, so both questions are valid. The first one, to answer your question on the data, there's tons of stuff in the NHANES data set. Obviously, I couldn't present all of it in this presentation because it's quite short, but there's loads of stuff that I could have added. So ranging from sociodemographic to clinical characteristics, there were even more patient-reported variables. So I'm in the process now of scripting a new model in Python, which incorporates additional variables and gives them different weightings, so we can use those and prospectively validate them. Stuff that wasn't collected in the NHANES dataset that maybe I would have liked to see were additional factors, clinical factors, maybe things like bleeding on probing and other measures of periodontal health, plaque scores, bleeding scores, things like that would have been nice because they would have been more clinically related to periodontitis. Your second question, which was you can get some weird associations. Yeah, I agree with that. And for the final manuscript that I'm working on for this, I'm developing 5 separate predictive models, then comparing the weighting that they give to each variable. So I'm using 5 different machine learning algorithms and seeing the weighting that they give to each variable that we assessed. And also I'm in the process of getting ethical approval to have these models validated on patients from the Birmingham Dental Hospital. So I'll look through their records, enter them into the models and see how they predict periodontitis. And I'll use their DPCs to confirm case definitions for periodontitis. So then we can see if these models, like you said, might have statistical significance, but do they bear any clinical significance?
That's great, thank you.
Just I think a very brief one from me. Thank you so much, great presentation. So you talk about using data from non-dental settings. What do you think the implications of this research are in terms of impact on the healthcare system, or how they could be used within the healthcare system?
A few things, but the main one is at-home screening. So the fact that patients can't get access to care right now, but as we know, periodontitis is implicated in both the development of other systemic disease, and it makes them progress more quickly, and it makes them progress to a worse state than they would if the patients didn't have periodontitis. The fact that we can screen for patients who have high likelihood of periodontitis outside of the dental setting is quite significant. But also, I've just presented in this presentation binary classification of periodontitis. What I'm also working on is when you get a score from the models, which ranges from 0 to 1. In this presentation, I said that if patients have a score above 0.5, we'll class them as periodontitis, but we can use it as a risk model instead. So patients above a certain threshold, let's say 0.8, we can rule them in as definitely having periodontitis, and then have a risk like low to medium risk between 0.2 to 0.8, and then have extremely low risk below 0.2. So instead of just binary classification, we can allocate resources to those at highest risk of having periodontitis as well.
Thank you. Thanks so much.
Thank you for answering those questions, Nasir. I will now play William's submission from the University of Cardiff. I'd now like to invite Prof Glennie and Prof Walsh to announce the winner of our 2021 British Undergraduate Dental Research Competition.
Hi. Well, I think the first thing that Prof Glennie and I would like to say is that we were really impressed by the quality of the abstracts that were submitted for the conference, also for the posters and the presentations of the finalists that made it this far. And it was great to hear the enthusiasm and the interest, and to see the diversity in the research that's being undertaken. But there can only be one first prize, and we're delighted to say that the first prize has gone to Nazir from the University of Birmingham. So well done, Nazir. But in a strange twist, we'd also like to make a change to the programme, because the quality of the presentations from William and Sathiam and their responses to the answers were so good. We'd also like to award them some smaller runner-up prizes. So well done to all 3 presenters.
Thank you all. It was really interesting. Great presentations.